Hi Callie, my name is Andrea. I am a nurse practitioner student and I will be performing a physical examination on your lymphatic, respiratory, cardiovascular, and peripheral vascular systems today. Thank you so much for participating.
You're welcome.
So we'll get started. I'll wash my hands. And first, we'll start with your lymphatic system. So I will be palpating or feeling various lymph nodes in your upper body. While I'm feeling them, I'll be naming them and feeling for size, mobility, and any tenderness, okay?
Okay.
So we'll start with the occipital nodes, posterior auricular, preauricular, tonsillar, submandibular, submental, supraclavicular, infraclavicular, posterior cervical, anterior cervical, deep cervical. And then if you could just lift your arm for me, please. I'm feeling for the subscapular, lateral, central, pectoral, and if you don't mind just bending your arm, epitrochlear. And then again on the other side, thank you. Subscapular, lateral, central, pectoral, and bending your elbow, epitrochlear. Good, thank you. All right, while I have you in a sitting up position, I'm going to start the respiratory exam on your posterior side, but first, just to note, while I'm talking to Callie, I'm assessing her for her respirations, the depth, any use of accessory muscles, intercostal retractions. I'm noting that she's not sitting in a tripod position or in no acute respiratory distress. I'm also noting the color of her skin, looking for pallor, cyanosis, of which she has none. So Kelly, I'll just have you turn around. We'll start with the posterior back. Normally I would have the patient's skin exposed. For the purpose of this video, Callie will keep her shirt on. So first I am inspecting Callie's skin of her posterior thorax. I'm looking for any signs of lesions or trauma. I'm also assessing for symmetry of musculoskeletal landmarks like her shoulders, her scapula, and her spine. I'm inspecting for symmetry of respiration, noting any lags or any distress with breathing. Moving into palpating. I'm palpating her posterior thorax, feeling for any crepitus or tenderness, palpating her costovertebral angle. I'm also going to palpate for diaphragmatic excursion, so placing my hands around her ribs, just at about the 10th rib or intercostal space, pressing forward for some skin, and I'm going to have Callie take a deep breath in and out. Good, and I'm looking for symmetry of movement between my thumbs. I'm also going to palpate for tactile fremitus in her posterior thorax. So with each hand placement, Callie, if you could just say 99.
99. 99. 99. 99.
Good. So moving on to percussion, I'm going to percuss the posterior lung fields. And I'm expecting to hear resonance. Good. I'm also going to percuss Callie's costovertebral angle. Good. Moving on to auscultation. With my stethoscope, I'll listen to Callie's posterior lung fields while she takes deep breaths in and out. Making sure that I stay at each site for full inspiration and exhalation. Good. So I would expect to hear vesicular breath sounds throughout the posterior thorax. However, I'm also assessing for any adventitious breath sounds like crackles, of which there could be fine or coarse. Fine crackles are non-musical sound with a high pitch. Coarse crackles or rails are also a non-musical sound but with a lower pitch. I'm also assessing for the presence of any wheezes, of which there were none. If I did happen to hear any adventitious breath sounds or inappropriate breath sounds for these lung fields, then I could go ahead and do a set of special tests for transmitted sounds. The first one, called egophony, is where I would have Callie say E while I listen to her lung fields with my stethoscope. And as Callie said E, I should expect to hear E. In a consolidated lung, that E would turn to an A through my stethoscope. The second test is bronchophony, where I would have Callie say 99, and in my stethoscope, in a normal lung, I should hear a very muffled 99. In a consolidated lung field, that 99 would become much louder and clearer. And then whispered patriloquy is the third test for transmitted sounds. I would have Callie whisper 1, 2, 3 through my stethoscope. I should hear nothing in a normal lung field. Again, with consolidation, I would hear some sounds through my stethoscope. So that concludes the posterior thorax physical exam. I'll have Callie turn around and lay down on the exam table for the anterior part of the exam. So again, first inspection, I'm again assessing for respiratory rate, rhythm, any use of accessory muscles or intercostal retractions. I am then palpating the chest wall for crepitus, any tenderness. I'm also palpating for tactile fremitus anteriorly. Again, Callie, with each position change of my hands, please say 99.
99. 99. 99.
Good. And I would expect to hear the vibration from the tactile fremitus. Moving on to percussion, I will percuss the anterior. Thorax. Again, expecting resonance. Good. And we'll move on to auscultation. I can just take normal breaths here. Again, listening at each site for a full inspiration and exhalation. I may hear some tracheal breath sounds here, and then the remainder of the lung fields should have vesicular breath sounds. laterally. Good. So that concludes the respiratory part of the physical exam. We'll move on to the cardiovascular portion. And the first thing I'm going to do is measure Kelly's jugular venous pressure. So to do this, I would have Callie sitting up, either at a 30 or 60 degree angle. I'm assessing, looking for, identifying her internal jugular vein. I'm looking for the pulsation of that. If I had a hard time seeing it, I could use tangential light, but I see it right here above her suprasternal notch. So that is the location where I'm going to place my straight edge, right at the top of that pulsation. And then with my measuring tool, I'm going to measure up to that straight line. And I have just about 2.4 centimeters, which is within normal range. So after that, I'm going to inspect and palpate the carotid arteries on both sides. First looking for any pulsations, and I'm palpating one side at a time for any thrills. I'm feeling brisk upstrokes. And then I will auscultate using the bell of my stethoscope. I'm listening for thrills. And Callie, if you could just hold your breath. Good. And there's no thrills auscultated on her carotid arteries. So moving on to the precordium. Again, first is inspection. I'm inspecting the precordial area at the right sternal border, second intercostal space, left intercostal border, second intercostal space. I'm moving down to the third, fourth, and fifth intercostal spaces at that left sternal border. This is also called Erb's point. And then the whole time I'm inspecting, I'm looking for any pulsations. Here, I'm also over here at the fifth intercostal space, left midclavicular line. So assessing for any pulsations. And then moving on to palpation, I'm going to palpate those same areas, right intercostal or right sternal border, second intercostal space, left, third, fourth, and fifth. And over to the fifth intercostal space, left midclavicular line is where I would feel for the point of maximal impulse, which I do feel at the left midclavicular line, fifth intercostal space. I could have Callie roll to her left lateral side to palpate that PMI if I couldn't while she was lying recumbent. Good. And you can go back onto your back. So after palpation, I'm then going to auscultate those same locations, first using my diaphragm. So moving my diaphragm across those locations, I'm listening to the aortic valve, the pulmonic valve, down Erb's point to the tricuspid valve, and the apex or the mitral valve. I'm going to have Callie roll to her side one more time while I use the bell of my stethoscope at that mitral valve while I assess for mitral insufficiency or regurgitation. Okay, good. Go back to your back. Thank you. Let me just help you up into a sitting position. I'll have Callie lean forward while I listen with my stethoscope to assess for any aortic insufficiency or regurgitation here. Lean forward. Good. And can you hold your breath? Good. Okay. So that concludes the cardiovascular physical exam, and we'll move on to the peripheral vascular exam. So like all systems, we start with inspection. I'm inspecting first the upper extremities for color of skin. I'm feeling for warmth. Assessing skin turgor. I'm assessing capillary refill. I am palpating the radial pulse and the ulnar pulse, as well as the brachial pulse. Good. And again on the other side, radial, ulnar, and brachial pulses. Good. Moving on, I would assess the femoral pulses right here, one, and then the other. Moving down the legs, assess the popliteal pulse and the left popliteal pulse. Good. I'm moving down the calf, palpating for any deep calf tenderness. As I near the lower extremities, I am assessing for any edema. I'm looking for warmth, any skin discolorations, and I'm assessing the posterior tibial pulse, the pedal pulse, and then on the right side, the posterior tibial, and the pedal, or dissalis pedis. Good. So that concludes the peripheral vascular part of the physical exam and concludes the entire physical exam for today. I just want to thank you for participating.
Thank you.